Okay. Okay, hello everyone. It's 7:30 p.m. now in Iran. It's time to start the program. So let's jump. We have 29 participants now. My name is Mantis Lymphoma. I am an associate professor of medical genetics at Hematology, Oncology, and Cell Therapy Research Institute at Tehran University of Medical Sciences and head of the leading house for Iran North America Academic Partnership, which has planned and organized this series of educational programs. First of all, I would like to thank you for joining us in our webinar, and we are honored to have you all with us. We are pleased to present the 10th part of the webinar series entitled CAR T-cell therapy in hematologic malignancies, which provides a great academic opportunity for Iranian hematologists and fellows to interact as well as share and exchange their knowledge and experiences with Iranian American experts in the field of hematology. Here, I would like to mention that this series of webinars on hematologic malignancies is scheduled and will continue until December. I also need to mention that in near future, we are going to come up with other series of webinars on non-hematologic malignancies and solid tumors, as well as other clinical subjects. So stay tuned for our announcement on the upcoming programs. Okay, now let's begin our today's webinar. But before we start, I would like to express my special thanks to Dr. Mazia Shadman, Associate Professor of Medical Oncology at the University of Washington, and also my appreciation to the Appraise to Raise team for their great effort and support making this program possible. Here I pass the microphone to Dr. Shadman to start the program and also to introduce our invited speaker, Dr. Armin Ghobadi. Dr. Shadman, please.
Thank you, Dr. Yagmai. Can you hear me well?
Yes, we can hear you.
Okay, so it's my great pleasure to introduce my good friend and colleague, Dr. Armin Ghobadi, for the talk on CAR T-cell therapy today. I can't think of a better speaker for the topic. Dr. Ghobadi is a graduate of Iran University of Medical Sciences. After moving to the US, he finished his internal medicine residency at the University of Texas Southwestern, UT Southwestern in Dallas, after which he completed his fellowship in hematology and medical oncology at the Washington University in St. Louis. He also finished an additional fellowship in stem cell transplant and immunotherapy at the MD Anderson Cancer Center in Houston, after which he returned to St. Louis and joined faculty at the Washington University as an assistant professor and later continued to work there as an associate professor. A well-known figure in the field of lymphoma and immunotherapy and CAR T therapy, Dr. Ghobadi is head for Center for Gene and Cellular Immunotherapy at the Washington University, where he oversees all clinical trials involving immunotherapy, including CAR T therapies, and he's also a very active member of Cellular Therapy Committee at the American Society of Transplantation and Cellular Therapy, ASTCT. He's authored more than 50 papers and book chapters on the topic, and as I mentioned, a very well-known figure in the field of CAR T therapy here in the US, and he's been involved in many of the landmark studies that led to the approval of the CAR T products for different types of heme malignancies. Thank you very much for joining us and for accepting this invitation.
Thank you very much, Mazia, Dr. Shadman, for inviting me. It's a great pleasure to talk here. Let me share and thanks for the nice introduction. Let me share my screen here. All right, you see my slide while in presentation mode?
Yes.
Yes, we can see your slide.
Awesome. Very good. Thank you very much again for inviting me here. I'm actually, for this talk specifically, I will focus on clinical aspects of CAR T-cell therapy and not much on a basic or translational side of CAR T-cell therapy, mainly focusing on advances in CAR T-cell therapy for heme malignancies, focusing on CAR T products that they are already approved by FDA for treatment of hematologic malignancies. And at the end, talk about some practical aspects of taking care of patients with CAR T-cell therapy. So these are my disclosures. I always show this because that's just this slide was from 2018 when looked at the number of active cellular therapy trials registers in clinicaltrial.gov. And at that time, we were around 800 clinical trials, half of them being CAR T-cell therapy. And as you see, majority of them in US and China. And this is just a couple of months ago when I looked at this website. This is actually a good website. I put the reference over there that you can look. They update it every couple of months. The number of active cellular therapy or what subtypes of cellular therapies that are out there globally, not just in the US. And as you see, the number of active trials went up from 700 to 2,100 clinical trial in 2021. And that number is expanding rapidly. Before 2018, let's say in 2010 or 2011, we just had probably handful of clinical trials in the world involving these cellular therapies and CAR T cells. So this just shows how fast this new platform is expanding. And as we know, as help patients with hematologic malignancies, but it's gonna affect all type of cancer in near future, hopefully. And these are the top targets. Again, I show this because main actually targets that you see are for hematologic malignancies, and there is a reason for that that I don't have time in this talk to go over it. But the number of active clinical trials using CAR T and cellular therapy for solid tumors and other malignancies is expanding rapidly. This is the overview of my talk. I will talk about CAR T for lymphoma first, subtype of lymphomas, and then ALL and multiple myeloma. And I have a couple of slides about point of care manufacturing because that's I think is going to be probably the main way or the only way of bringing CAR T cell therapy for a fair number of patients in future in some corners of the world. As I will discuss, manufacturing centrally and shipment of these cells to other countries logistically is difficult and is extremely expensive. So one can imagine in a near future, the way that we do autologous transplant, you actually manufacture your CAR T cells in centers of excellence in multiple centers around the world. Cancer cells evade immunity because of various reasons. Cancer is called cancer immunoadhesions and or immune evasion. One of the main reasons is downregulation of MSC class 1. Basically, the same way that the T cells can see malignant cells if the tumor-associated antigen presented to them in the setting of MSC class 1. And cancer cells, one of the main mechanism of resistance or immune adhesion is downregulation of MSC class 1. There are other mechanisms, but that's one of the main mechanisms. And the reason that I say that because the CAR T cells and T cell engagers or T cell redirectors, they are going around this mechanism of resistance that is downregulation of MSC class 1. Specifically, here in a CAR T cell, that's the T cell that has a chimeric antigen receptor as a binding site for a tumor-associated antigen, so it can bind to target cellular tumor cells without presence of MSC class 1. T cell redirectors, including BiTE, DART, and so on, they do the same thing. Obviously, there's a long list of class of cellular therapies that help our immune system to go around cancer immune addition or immune evasion. And today, I will talk about CAR T cells and mainly clinical side of CAR T cells. So CAR is called chimeric antigen because there's a combination of two things together. And that's basically a B cell receptor or antibody, that's B cell receptor binding site of an antibody combined with the intracellular activating domain of a T cell receptor in a single chain. And that is why it's called chimeric antigen receptor. The first generation, and this is a cell membrane here, this first generation at the binding site and zeta chain as the intracellular activating domain was not very effective and took several years to add co-stimulatory molecules like CD28 and 4-1BB, and that list actually is expanded now. And when the second co-stimulatory domain was added, the efficacy of the CAR T and preclinical went up significantly and in clinic. So most, actually almost all CAR T cells that are in clinical trial and the one that you are approved, all of them are second generation CARs. That means they have zeta chain and one co-stimulatory domain of CD28 or 4-1BB. And this co-stimulatory domain actually makes some changes in terms of activity, expansion, and side effects and persistence of CAR T cells. In general, CD28 CAR T cells can expand rapidly and they can fade away quicker. And 4-1BB ones expand slower and remain in the patient circulation significantly longer. And this is the a schema of basically when we are treating a patient using autologous, not using allergenic or off-the-shelf CAR T cells. Autologous CAR T, those are that have been approved, all of them are autologous CAR T cells. So the first step is collection of T cells from the patients, leukapheresis, right? Usually 2 to 3 hours of leukapheresis. And this is not mobilized pheresis, that like the way that we collect the stem cells for transplant. This is just steady state leukapheresis that we do. You collect peripheral blood mononuclear cells that include T cells, so as all other cells too. You send it to a GMP facility or a setting of an approved product goes to a manufacturing GMP facility, you ship it. And over there, T cells are isolated. And that T cell isolation actually, there are different methods of doing it, and that's a part of signature of that product and cannot be changed. So T cells are isolated. When I say this, for example, between Yescarta or Axis cell and Tecartus or KTX19, the only difference in those two products that they have two names, two labels, two different indications is the way that T cells are isolated. The actual chimeric antigen receptor molecule in both products is exactly the same. The rest of processing is the same. Just the way that T cells are isolated are different, and that's why you have two different products. So T cells are isolated and stimulated, and usually expansion doesn't happen here. After stimulation, then gene editing, if you want to get rid of a T cell receptor or additional gene editing, is done at that time. And then transduction of gene happens. So obviously when you are trying to have a cell that has a chimeric antigen receptor, we have to put the gene inside the T cells. And that process is called transduction. And transduction, through transduction, basically you insert the gene that can make chimeric antigen receptor protein for that cells and use various methods of transduction. The most commonly used ones are lentivirus, using retroviral vectors, or non-viral vectors, actually getting some traction now because they are less expensive. So this, if you look at the car, like an actual car, this part, transduction with a vector, is really like an engine of your car. So if you want to make a car, the most important part of having a car is being able to have an engine. And this is the bottleneck for manufacturing, even for the approved products, making the vectors. So if a country or a university or a center of excellence want in the future to be independent and being able to make CAR T cell need to come up on its own or with collaboration with other centers, come up with a way that you can make your vectors. So if you make your vectors for your CAR, the rest are really easy. So the transduction happens, and with the transduction using lentiviral or retroviral, then the gene inserted in the T cell, and that gene makes chimeric antigen receptor that goes to the surface of the T cells. And you call that T cell CAR T cells. That's a T cell that has a chimeric antigen receptor on the surface. Expand them, and then usually an autologous that are shipped and frozen in a bag with DMSO, shipped to the center. And when you have it in our treatment center, you give usually 3 to 4 days of conditioning with fludarabine and Cytoxan. That is called lymphodepleting chemotherapy. So it's kind of like opening a space for expansion of this cell, so they're not going to be rejected because of chimeric antigen receptor that they have. And there are other reasons for adding fludarabine. But you get usually 3 to 4 days of fludarabine and Cytoxan. That is a low dose. It's similar to, for oncologists, basically is the FCR without Rituxan. One cycle of FCR that we give for CLL patients, you just don't give a Rituxan part of it. So you give that for 3 days, you wait a couple of days, and then you bring your frozen CAR T cells in the patient's room, thaw and infuse the cells. And we usually, majority of centers, not all centers, you keep the patient for at least 1 week in inpatients for monitoring of a side effect. And you look at the response a month after infusion of the CAR T cells. We usually see this patient once a week in the first month, every 2 weeks in the second month, then monthly for a few months for monitoring of side effects, response evaluation, and management of their adverse events. So in terms of, so that was the schema for CAR. So when I'm talking about the clinical trial, I'm going to go over a schema quickly because this manufacturing and almost all of those autologous products are the same. The process from leukapheresis to actually shipment of the cells back to you or a vein to vein ranges from 3 to 5 weeks. And during this 3 to 5 weeks of manufacturing, some studies or in practice, you can use some chemotherapy to keep the disease at bay, or some trial, they did not allow you to do that. So that treatment that you use from leukapheresis to return of a product to you during that 3 to 4 weeks is called bridging therapy. So CAR T for lymphoma. The first actually chimeric antigen receptor T cell that was approved for lymphoma was for DLBCL and was axi-cell. So diffuse large B-cell lymphoma is the most common subtype of lymphoma. Around 1/3 of them with a standard chemotherapy, or when they relapse with autologous transplant, they relapse after autologous transplant. So if you look at all DLBCLs, all comers, around 1/3 of them are going to be relapse refractory. Before CAR T cell, almost all of those patients, they were dying of their cancers. And CD19, there is a reason that was used in a lot of clinical trial and the most commonly used target for a CAR T because the low-hanging fruit, really. You have it in almost all B-cell malignancies, and in terms of normal tissue, you just have it on your B cells. So basically, the on-target, off-tumor effect is just going to be a B-cell aplasia that we'll talk about. So B-cell aplasia, we know with the Rituxan, use of Rituxan doesn't cause a significant problem for patients. So the first trial that we'll talk is ZUMA-1. ZUMA-1 was a phase 1/2 trial that used the CD19 second generation CAR with the CD28 co-stimulatory domain called axi-cell. And that was the first one that was approved for lymphoma. So the one important factor here is just in terms of a timeline from the first patient that we enrolled. Actually, that was first patient was enrolled was on this trial was at WashU as our patient. So the first patient that we enrolled to the approval, finishing phase 1, 2, and approval of this product for lymphoma was less than 2 years. So for people that are involved in a clinical trial at US and the approval process, this is an extremely fast process. In this trial, patients with DLBCL, transfer follicular lymphoma, and primary mediastinal B-cell lymphoma, those are all called large B-cell lymphoma. They were enrolled when they have failed at least 2 lines of therapy. So as a background for people that they are not oncologists or hematologists, so when you have a patient like that, especially diffuse large B-cell lymphoma part of it, failing 2 lines of therapy or coming back after autologous transplant, the chance of responding to any salvage chemotherapy is around 25 to 30%. The chance of achieving complete remission is roughly around 5 to 7%. So when in this basically trial, those patients were enrolled. And the schema is the same basically, a screen, leukapheresis, and then bring manufacturing the cell and bring in the cells and infusion of the cells. So the one thing here, the grand schema, bridging chemotherapy was not allowed here in this trial. Majority of patients, 70% of them failed 3 lines of therapy actually, and around a quarter of them were relapsed after autologous stem cell transplantation. So basically a really resistant group of patients. And this is a response rate. So overall response rate was around 80% with 55 to 60% complete remission. So that's compared, obviously this was not a randomized trial. So you didn't have a standard of care arm. So historical data, those group of patients, the chance of response 30%, CR rate 5 to 10%. Here, overall response rate 80% and CR rate 55 to 60%. So it's dramatically better than the standard of care. And as you see in terms of progression-free survival, there is a plateau there. And probably, with the longer follow-up, we think that around 35 to 40% of these patients are long-term survivors, that they are cured from their disease. As you see, from the day of infusion till achieving this plateau is around 6 months. So really after giving this cells axis cells, 6 months time point is a critical time point. Patients that they are in complete remission, 6 months post-infusion, more than 90% of them stay in remission 2 years later. So that 6 months time point is a critical time point for prognostic evaluation of these patients. So based on the result of this product called Axi-cel or Yescarta was approved in 2017 for patients with relapsed refractory large B-cell lymphoma failing 2 lines of systemic therapy. This is just one example of one of those patients. So on left is a patient who failed basically 7 lines of therapy. And those, that black burden is obviously burden of disease. As you see, a month later after infusion of Axis, the patient is in remission. And when it's working, it's really extremely effective. And you see it actually when you see the patients, when, for example, if they have a leg pain or if you have a leg swelling because of basically a lymphoma pushing on their lymphatic drainage, within few days you see a significant improvement when it's working. There are obviously 2 other products that are approved, Tisa-cel or Kymriah, Lysocell or Breyanzi. Those are all approved for this indications with the same, basically kind of a similar indication with some minor differences. I summarize them and they are here. Obviously, interest of time, I'm not going to go over the detail of those, but we have those 3 products, all CD19 CAR, with some minor differences that I go over them that we can use for our patients. I went over the Axi-cel or Yescarta. In terms of Kymriah or Tisa-cel, this is a CD19 4-1BB second generation CAR. Overall response rate, when you look at it, it seems that is less than Yescarta when you look at the CR and overall response rate. But I think the response rate only is not the major, most important thing. Obviously, progression-free survival is the main thing. And there is no much difference between these 3 products to me in terms of a progression-free survival at 2 to 3 years. All of them are close to 30, 35%. In terms of indications, for example, Tisacel or Kymriah is not approved for primary mediastinal B-cell lymphoma. And Breyanzi is approved for follicular lymphoma grade 3B. In terms of side effects, there are some differences. Obviously, those studies have not been compared head to head. The way that you treat side effect or adverse event is different from center to center. So I don't think that you can look at those papers and say, oh, grade 3 neurotoxicity 30% and 10% with the other one. So that's going to be the same. How you manage CRS and neurotoxicity in these trials is really affecting your overall number significantly. For example, if in a trial, you are allowed to start tocilizumab and a steroid for management of side effect early on, and grade 1, for example, CRS, you can end up having a significantly lower rate of grade 3 CRS or even ICANS or neurotoxicities. So having said that, there are some differences, and I've seen it between those products in terms of adverse event, peak to adverse event, and those kind of things. And based on those, we decide what product we're going to use for our patients. So if I have a patient and I have all 3 products that they can choose from, I'll look at what are the factors that I look at. One is manufacturing. What product is going to give me the fastest manufacturing slot and manufacturing turnaround? Because this patient, when they have active problem, is going to take a long time for them to make it. Then patients can die of disease progression. So that's the first and most important thing. Second is their comorbidities. If the patient is older, cannot tolerate high-grade neurotoxicities, I may go with the Tisacel or Lysacel that have less rate of neurotoxicities. If a patient has a high burden of disease and I want to go after the disease really strong, quickly, and hit it fast and a strong CD28 CAR, Axicel is going to be a better option to choose from. So this is just the way that I look at it. It's not based on a randomized studies or real data. For CLL, so actually the first NEJM New England Journal of Medicine paper was a CLL. Last when that study was published, 3-4 patients went to complete remission. Then was an explosion of interest to CAR-T. But later on, when the studies were done, CLL actually was not, CD19 CAR was not as effective against CLL when you compare with diffuse large B-cell lymphoma. And the reason for that is various reasons have been proposed, including the function of the T cells. And there are studies preclinical showing that when you add ibrutinib, that can enhance the function of T cells and your final CAR T cells. So those studies, combination of CAR T plus other agents, one of them is BTK inhibitors, mainly ibrutinib, not other BTK inhibitors, can enhance the function of CD19 CAR for CLL as well. There is no approved product for these patients. So this is one example of CAR-T for CLL that published in Nature that if you have not read it, I recommend actually reading this paper. So it's a very interesting paper, just 1.5 pages. So basically in this study, they showed that in one patient that had more than 20 pounds of CLL tumor in the patient's body, when they gave CD19 CAR, just one single CD19 CAR got rid of the whole burden of disease in this patient. So that just tells you basically a strength and the function of CAR T cells when they can do they can do their job. Basically, one single CAR T cells, when they are killing the cancer cells, they expand and the number goes up. One single CAR T cell expanded and got rid of the whole more than 20 pounds of CLL in this single patient. What about Mantis Lymphoma? That's this product, KTX19 or Tecartus, is approved for Mantis Lymphoma based on the result of ZUMA-2. So Mantis Lymphoma, people who are taking care of Mantis Lymphoma patients know what they relapse, and we don't have any curative treatment for it other than allogeneic stem cell transplantation. And when they relapse, especially relapse after autologous transplant, And when they have aggressive features, really, they have a short disease-free survival, few months, 6 to 10 months, and they die of their disease. So in this study, patients failing 2 lines of therapy with mantle cell lymphoma were enrolled, and bridging therapy was allowed. And this is the overall response. 93% of those patients responded, with 67% achieving complete remission. So that's obviously dramatic. And this is another important practical, actually, when you're taking care of these patients, that 67%, close to 70% complete remission. It doesn't happen all the time 1 month after infusion of the cells. Actually, half of the patients that they were in complete remission, they were not in complete remission 1 month after infusion of the CAR T cells. When you look at them 3 months later or 6 months later, they were going to remission. And this is in terms of duration of response, patients that they are responding, around 60% of them, 2 years later, they're still in remission. So that's a fairly good number, but we don't have a long-term follow-up, 5, 10 years to say those patients are cured. Hopefully a fraction of them are cured. And this is the progression-free survival and overall survival. So based on the result of this, FDA approved Tecartus for mantle cell lymphoma patients. Again, the only difference between this KTX19 or Tecartus and Axi-cell or Yescarta is the way that T cells are isolated. Mantis cell lymphoma, as you know, you can have circulating malignant cells. So the way that T cells are isolated and manufacturing of Tecartus is actually positively selected CD4 and CD8. But for Axi-cell is that just centrifuging, buffy-coat, and collecting the T cells. So you can have, if you do that process, you can have a malignant T cells in your product that you are transducing with the CAR, and there are publications that when you do that, you can come up with the resistant phenotype. So you couldn't obviously use the same manufacturing of Axi-cell for manufacturing CAR T for mantle cell lymphoma or ALL. And because of that, because you're changing one part of it, then that's not, even the CAR molecule is the same. Final product should have a different name. What about follicular lymphoma? Axi-cell is approved for follicular lymphoma. That's been the same product that was approved for large cell lymphoma based on the result of ZUMA-5. These are patients with follicular lymphoma or marginal zone lymphoma failing at least 2 lines of therapy were enrolled in this trial, around 150 patients. And this is the response. And 93% in follicular lymphoma, around 95% of patients responded. And 95% of patients responded. And CR rate was around 80%. So that's, even for follicular lymphoma failing 2 lines of therapy, that's significantly better than what you expect in these patients. Marginal zone lymphoma also, a lot of patients responded. A large number of them responded, 80% overall response rate and 75% CR rate. But in terms of a duration of response, for some reason, patients with marginal zone lymphoma lost their response quickly. And we don't know why, but follicular lymphoma is still 2 years later, 70 to 80% of those patients are still in remission, the one that they went to remission. Based on this result, Yescarta or Axi-cell was approved for patients with follicular lymphoma failing at least 2 or more lines of therapy. What about T-cell lymphoma? So T-cell malignancy is a different, more difficult problem to go after with CAR T cells. So as you can imagine, the T cell that you use for manufacturing of basically your CAR T is going to go after a target that you have it on the surface of T cell malignancies. So because almost all of those targets are on the surface of normal T cells, so the CAR T that you make is going to kill itself. It's called fratricide. And that's going to be a challenge in making a CAR T cells against T-cell malignancies. So Matt Cooper and John DiPerzio lab in our group actually developed one of the first CAR T cells for T-cell malignancies, so against CD7. So what he did, the first thing using CRISPR, got rid of CD7 on the surface of T cells. So get rid of CD7 gene. And then the other problem with the T-cell malignancies is when you are collecting, let's say, as a T-cell ALL, when you're collecting T-cell for manufacturing of CAR T, your product is contaminated with malignant cells. So if you transduce those, you're going to end up with the resistant phenotype. So you cannot use patients' own T cells for manufacturing CAR T for majority of T-cell malignancies. So you have to come up with the off-the-shelf or allergenic T cells. So when you do this, allogeneic T cells obviously can cause graft versus host disease. And you don't want to do that. So the graft versus host disease happens through the TCR pathway. So to prevent a T cell from causing graft versus host disease, you have to get rid of T cell receptor. So we're using CRISPR, basically got rid of T cell receptor track or T cell receptor alpha chain, and then transduce that T cell with the CD7 CAR. So you have a CD7 CAR that doesn't have a T cell receptor and doesn't have a CD7, fratricide resistant and GVHD free off the shelf T cells. And this product actually just was licensed to a company, a startup company here around WashU. And the first trial, we just got the IND clearance to start the trial a couple of weeks ago. So the first trial using this product is gonna be started very soon. And this is in mice model showing that it's working very well. What about ALL? So ALL, the first CAR T CD19 CAR that was approved actually was for ALL. Was Kymriah or Tisacel that was approved for ALL before even Axi-cel being approved for diffuse large B-cell lymphoma. So ALL, patient with ALL, when they relapse, especially after the second relapse, their survival is extremely poor, with 95% of patients dying of their disease finally. So it's a very difficult disease when it's relapsing. At that time, when this was done, we didn't have even belantamab and atezolizumab, and even with those two effective treatment, still relapse is very high. So this was as I said, Tisacel in patient, children and young adults up to age 25 with ALL. I don't have a patient list here, but almost all of those patients were relapsed ALL after allogeneic stem cell transplantation. So for hematologists who are taking care of patients with ALL, you know that when a patient is relapsing after allogeneic transplantation, those are very difficult patients to manage. Almost all of these patients will relapse after allogeneic stem cell transplantation. Around 100 patients enrolled. And the response rate was 80%, and all of them MRD negative. So that's a lot more than what you expect with the standard chemotherapy, close to what you expect with inotuzumab, but duration of response with inotuzumab, that is antibody drug conjugate, is not good. Almost all of those patients relapse when they get inotuzumab. So very good in response. And without transplant, even around 60% of these patients are disease-free a year later. And know that there are longer follow-up, most likely even without consolidation with transplant, around half of this patient, especially the one that they have persistent B-cell aplasia or cure from their leukemia. And based on this product was approved by FDA, as I said, for children and young adult up to age 25. What about adult ALL? Adult ALL is the really more difficult disease to manage with CAR T. This is the largest, just published in Lancet actually, a couple of months ago. This is the largest CD19 CAR T trial for adult ALL, ZUMA-3. And patients for adult ALL, when they relapse and when you're trying to give them, I don't have time to go into detail of logistics of it, but it's in general is a lot more difficult than lymphoma to manage with CAR T cell because of various reasons. In this study, patient with relapsed refractory ALL, adult with relapsed refractory ALL were enrolled. And bridging therapy was allowed. And this is, again, this is Tecartus or KTX19. 71 patients enrolled, 55 patients finally got the product. Around 10 to 20% of patients, their disease is progress and they get sick so quickly that they cannot get the CAR T. These are patients, around 40% of them were relapsed after allo. And close to half of them had the relapse post anatuzumab or belantamab. So really group of refractory ALL, adult ALL. And this is the overall response rate. Overall response rate, basically all of them CR or CRI, 70%. 70% of this patient achieve CR or CRI. That's a very good number for this group of refractory patients. This is a modified intention to treat basically among patients who got actually the CAR T, not all that we started with. And those patients that they get CAR T, as you see, still, even when they go to remission, they relapse. We have a short follow-up. Probably 40 to 50% of those patients, 1 to 1.5 years later, 18 months later, is still, especially the one that they achieve CR and CRI, they're still disease-free. But we don't have a long follow-up in these patients. And this product, because of the efficacy of it, is under review by FDA to be maybe the first approved CD19 CAR T for patients with adult ALL. What about multiple myeloma? Multiple myeloma, as we know, is a very common blood cancer, is not curable with current treatment. And the hope is, with the combination of CAR T cells, T cell redirectors, antibody drug conjugate, immunomodulator, and all of those, the same way that lymphoma and Hodgkin lymphoma with ABVD and CHOP, with those combinations, we had the final cure for those patients, with a fair number of them. I'm hopeful that with the combination of CAR, so far, I thought that the CAR is going to be curative for this patient. So far, that has not been the case. But I'm hopeful that with the combination of CAR, with T cell redirectors and other platforms, this multiple myeloma that is ugly cancer is going to be changed to a cancer that we can cure, especially because affecting middle age and patients, and is a very tough disease when it's just coming back, and you run out of your options for treating them. So there are various targets for multiple myeloma. Some of the ones that are mainly being targeted, I put them here. BCMA is the one that is a target for the one that is approved by FDA, and the second one that is under review for approval by FDA. Both of them are against BCMA. But there are other targets in development as well. And this is just one list of them, short list of them. Based on the result of this study, BB2121 is BCMA CAR with 4-1BB co-stimulatory domain. This product was approved for relapsed refractory multiple myeloma. As I said, there's a 4-1BB second generation CAR against BCMA that you have it on the surface of multiple myeloma cells. This study, various doses of CAR T cells were used, from 50 million to 800 million, finally landed on 450 million as the dose. And those patients that they got more than 150 million, 95% of them responded to treatment, with around 50% of them being a stringent CR. So for people that treat multiple myeloma, these numbers are very, very good. These patients would relapse after multiple lines of therapy, and usually options that you have for this patient, you don't get even close to this level of response. But this was the disappointing part. Even the patients that they achieve MRD negative on minimal residual disease negative, basically a status, half of them half of them relapsed 18 months later. So obviously that was disappointing because we're thinking that those MRD negative, maybe a fraction of them are going to be cured, they're going to stay in remission, but that wasn't the case, and that's not the case. So I don't have time to go over the details of this, but obviously people are thinking how we can make this better. What was the problem with this product or this group of patients that were enrolled? Do you have to treat it earlier? Do you have to make some changes in the way that we give the CAR T cells? Do you have to give more than once? Just 6 months later or 12 months later, give a reduced dose or with reduced lymphodepleting chemo. So people are basically using this as a start for multiple myeloma. And there are multiple clinical trials using different targets, including BCMA, with various strategies that going after this that hopefully is gonna result in a better progression-free survival and maybe some cure. So this product was approved for patients that have failed at least 4 lines of therapy with multiple myeloma. There is another product that is very promising. I want to make sure that I'm not going over my time here. Okay, I have a few more minutes. This product probably is going to be the next one that is going to be approved by FDA for patients with multiple myeloma. This is a product that was developed actually in China, a company named Legend, and then joined with Johnson & Johnson and developed a larger trial in North America, Europe, and China that completed. And the result of that study that I'm going to present here is under review at FDA. And the way that looks most likely is going to be approved as its second BCMA CAR for patients with multiple myeloma. So this product actually has 2 binding sites against BCMA. So it's not just the SCFE, 1 binding site against BCMA like Abecma or BB2121. This is called cilta-cel. And actually there's a typo here. It's just 1 L in cilta-cel for multiple myeloma. And patients with relapsed refractory multiple myeloma were enrolled in this study, around 100 patients. And this is the response in these patients. 97% responded, and 80% of them with astringent CR. So this is amazing. Basically, it's just dramatically more than what you expect with chemotherapy or even newer advanced therapies for multiple myeloma. 80% astringent CR. And even, obviously, you can't do cross-trial comparison because of patient differences, but with Abecma astringent CR, it was 50%. The other good thing about this product is patients that they went to CR, even all comers, 18 months disease-free survival was around 70 to 80%. So it seems that progression-free survival in these patients in this study with this product at 18 months was better than what we saw with Abecma. We just have to obviously see this with a longer follow-up and see if maybe a fraction of those patients are cured from multiple myeloma. But this is very exciting result with this product, and as I said, is under review. So what about the problems? I will talk about the side effects in a couple of minutes. But in this specific study, 5 patients developed what we call it neurocognitive disorders, like Parkinsonian-like disorders, with movement disorder, problem with memory, and those kind of things. And that caused some concern about this product. Some changes in how to manage CRS and select the patient was done in the subsequent 100 patients, and just 1 out of 100 patients developed similar symptoms. So we just have to watch for this. Obviously, side effect management is a major part of CAR T cell therapy. What about point of care manufacturing? As I said, let's say in an ideal situation, Tehran University Cell Bar Therapy Lab is going to make CAR T cells in the GMP facility over there for the patients. So here we did that. Some of the centers in the US already have done this for several years. We started this a couple of years ago and got engaged in manufacturing of actually CAR-T in our center. So it's a complex process. There's a lot of learning point there, but it's doable and has actually advantages compared with the frozen products. So I'm just gonna go over this. So one thing is all the manufacturing process, you can combine all of them in one device. It's called Prodigy. And I know a lot of centers in the US and around the world are using that. Second advantage here, I told you when you are manufacturing the CAR T cells, you have to collect the leukapheresis, collect your T cells and ship it and wait 3 weeks later for the cells to come back. And then you start your lymphodepleting chemotherapy. So from freezes to start the lymphodepleting chemotherapy takes around 3 weeks and the cells are frozen. So we, in this trial, actually, we had, with collaboration with Case Western, we had the point of care manufacturing of CAR-T, manufacturing the CD19 CAR-T with CD28 co-stimulatory domain on the site. So we're collecting the patient's T cells, sending it to our GMP facility, and manufacturing time, instead of actually 3 weeks, was 12 days. We could shorten it even to 8 days. The other important thing here is because we are manufacturing on site, we could do it, we could give it fresh. And because Flu-Cy is not myeloablative, we didn't have to wait for the manufacturing to be done and then infuse the cells. So what we did basically, we're collecting white cells, waiting 3 to 4 days later, starting lymphodepleting chemotherapy. And 12 days after collection, we had the CAR-T cell product manufactured and infuse it. So basically time from leukapheresis to a start lymphodepleting chemotherapy decreased from 3 to 4 weeks to 3 days. So that's dramatic for these patients. And you are giving it fresh. So when you freeze the cells and thaw, people who are doing that know that you lose around 30% of the cells, roughly 20 to 30%, and their function can be sluggish. So there are a lot of advantages to a point of care manufacturing. The result of this study actually is going to be presented at ASH this year. This is one of the patients that we gave. What about adverse event? CAR T cells obviously are very effective. There are 5 of them that are already approved, but they have significant side effects and toxicities that can be very overwhelming and scary if you don't have enough experience to manage those. Overall, in terms of dying of complications of it, is similar to what we see with autologous stem cell transplantation for lymphoma. So there are, when you have the CAR T cell, when you infuse the cells, what are the things that you expect? Is CRS, that means the expansion of T cell happens. You can have fever, chills, activation of your immune system, drop in blood pressure, hypoxemia, and those kind of things called cytokine release syndrome. Those patients can develop brain toxicity or neurotoxicity. We call them ICANS or immune effector cell associated neurotoxicity syndrome. That usually start. I'm going to go over to the next slide. Usually CRS happen in the first 7 to 10 days, and then a day or two after the starting of CRS, you have this neurotoxicity start. That's confusion, problem with Okay, you have confusion, problem with memory, and those kind of things, and also seizures, brain swelling, and in the worst case scenario, dying of those. So the main treatment for those is going to be IL-6 directed therapy, tocilizumab, and a steroid. In the interest of time, I just lost track of the time. I don't have time to go over those, but you have this slides, you can take a look at them. But we keep the patient usually for about a week, and we look at those side effects, and we have an algorithm that usually follows the ASTCT guideline that has been published for grading and we have our standard management using tocilizumab and steroid for management of these patients. So I go over this. Cerebral edema is one of the worst side effects that can happen. Happens 1% of the time, and is deadly unless you recognize it quickly and go after it quickly. Usually happens between day 5 and 10, and the chance of that happening is less than 10%. Other side effects are prolonged cytopenia, B-cell aplasia, and hypogammaglobulinemia that can happen. So we have to support patients during those times with antibiotic prophylaxis and growth factors. And also we have to give prophylaxis for management, prevention of infections based on a published guideline. I put the reference over there, we follow that. And I go over this. We look at IVIG, immunoglobulin level. If it's less than 500, we give IVIG monthly. Replication competent retrovirus and lentivirus. I don't have time to go over this. Potential risk has never been reported, but we watch for it. Financial toxicity. This is very expensive. It costs the prediction of effect of this in the U.S. budget in the next 5 to 10 years for just 2 products is around $20 billion. So it's very expensive. Local manufacturing, regional manufacturing is going to be obviously key in bringing these products to all other parts of the world, because $500,000 is just impossible to give for a product for a patient outside of the U.S. really. And this is for referring physician that I bypass. And those are the five approved products that we already talked about. In summary, CAR-T and cellular therapy is expanding rapidly. There are already 5 approved products. This is just the start of a wave that I think is going to dramatically change the way that we treat heme malignancies and solid tumors in future using other type of cellular therapies as well. There are challenges, side effect, efficacy, broadening the indication for other heme malignancies and solid tumors that needs a lot of help from young people and future scientists and physicians to take care of. With that, thanks for listening. I would be happy to answer any questions that you have.
Thank you, Dr. Ghobadi. And thank you for attending this session. Very nice presentation, very comprehensive and helpful for us. Actually, at this moment, CAR-T cell therapy is not available in Iran, but of course, many researchers are working hard to run it as soon as possible, and I hope we can access it in near future. There are some questions I think I can ask some of questions from the chat box.
Absolutely.
I want to know your opinion about the CAR-T cell therapy in ALL patients, especially in relapsed refractory ALL patients. Do you think the CAR-T cell is a bridge to all HSCT, or CAR-T cell is a definite treatment?
Yeah, sure. That's a very good question, and actually we wrote a paper with John DiPerzio and one of our fellows who was at the City of Hope now, Dr. Scott Goldsmith, that we reviewed actually all the data that is out there in this regard. So person who asked this question, I encourage to take a look at it, because obviously I can't go over it. It's a very complex question and it's difficult to answer, but I can say CAR-T cells and an allergenic transplant are not competitors. That was the purpose of that. I think it's going to be probably complementary. And there are, as of now, in a pediatric and young adult that they get CD19 approved product that is 41BB, people are not taking them to transplant if they achieve complete remission, MRD negative. For adult, that's a different story. So, and there are studies looking at CD19 aplasia after giving the CAR-T. So let's say if you give it to a patient and still 6 months later, you have B-cell aplasia on that patient, the chance of that patient being cured is significantly higher So you can do, when you say B-cell aplasia, you can just do a peripheral blood flow at various time points after infusion of the cells. And if 6 months later, 12 months later, still have B-cell aplasia, those patients, the chance of being cured is significantly high. So there's no reason to take them through the allogeneic transplantation and the hassle of graft versus host disease and side effects of transplant. For adult ALL, we don't have long-term follow-up, and the one that is CD28 in the Lancet paper, we actually touched on this transplant, no transplant, that didn't make a difference in those patients that they got transplant or not transplant. And also there's another New England Journal of Medicine paper from J. Park MSKCC group that they looked at MRD negative one, an adult getting allo versus no allo, and the progression-free survival is exactly overlapping. So the short answer is really, if you achieve MRD negative CR with the CAR, you don't need allogeneic transplantation of patient with ALL.
Thank you. And another question about dual CAR T cell targeting, CD19 and CD22 dual CAR T cell. What's your opinion about this product?
So yeah, going after multiple targets, that mainly is 2, but some people are thinking about even more than that, is obviously has an attractive actually platform because of various reasons. One is usually people that they relapse after CD19 CAR, around 1/3 of them, they have lost the target. When I say they have lost the target, that means probably there was a clone that was CD19 negative, or CD19 got mutated, and then they develop resistance. Actually, with the T-cell cellular Kymriah, there's a Nature, I think Nature or Nature Communication paper that you can look at. Interestingly, those patients that they had CD19 negative, all of them, they had a mutation in CD19 that caused CD19 to be truncated. So it's not going to be expressed on the surface of T-cell. And that happens surface of malignant cells. So that happens in around 1/3 of patients. With lymphoma is less, but we see it. So going after 2 targets, first of all, helps to prevent relapse because of losing 1 target. Secondly, is going to be, there are preclinical data showing that it's going to be more effective. Let's say if you have the same effective to target ratio in a dish, and you put CD19, CD20, or combination of CD19, CD20, with the same E to T ratio, the one that they have 2 targets, or a mixture of them, 2 CAR and 1 T cells, or a mixture of CD19, 20 CAR in your product, the response is better when you're going after 2 targets. Has been obviously multiple trials that some of them have been published, looking at target CD19, CD20. What is going to be this product that they are against 2 targets, they're going to land? I think most likely, if they are as effective as the let's say against CD19 only, there is no, if they are more effective, yes, they're going to be earlier and going to be used before even single target CARs. But as of now, their efficacy is similar to single target. So my assumption is, at least for now or in the next few years, the main advantage of those dual targets are going to be against where the patients relapse after basically using a CD19 targeted therapy or BCMA, and you relapsed, and you go after use one of those two target directing CAR T cells, for example.
Thank you so much. One of our audience, Dr. Rashidi, asked a question about role of CAR T cell therapy after transplant in acute leukemia. I think you answered during your talk.
One point I think Armin, Dr. Rashidi, is we have the same first name, my close friend of mine. So I think he's asking what's going to be, if I'm not mistaken, what type of cells are going to be used. Is going to be risk of GVHD or something like that. So when relapse after allogeneic transplant happens, and for example in Eliana trial, or the ones that you have used for adult, So the T cells that you collect from a patient actually is a mixture of T cells from the donor and from the recipient, because this patient, they have mixed chimerism. For the transplanter, basically your T cell is coming from the donor and some of them from yourself. So ended up the product that you have having a mixture of T cells from the donor and recipient. And those T cells, when they have been used for manufacturing of CAR T cells, they have not caused graft versus host disease or recurrence of or worsening of graft versus host disease. In terms of response, as I said, for example, in Eliana, almost all those patients were relapsed post allergenic transplantation, and 80% of them went to CR MRD negative.
Thank you. And another question from my friend, Dr. Azadeh Kumarsi. What's your opinion about NK CARs and their application in myeloid malignancies?
So NK is another attractive platform. And because of various reasons, one of them is basically side effects. People have actually, we have scientists here at WashU that they are very focused on NK and iNKT, and this is obviously, as we know, is the spectrum of these cells and how you change them. We call them, some of them, simul NK. But that platform is being investigated extensively, and people who follow that, the NK as a source of CAR, they know Dr. Rizvani's paper that was published in New England Journal of Medicine. She's one of the, she's originally from Iran as MD Anderson, and she has done a lot of good work in terms of using NK cell as a target. And they published the result of their trial using a cord blood, actually, T cells for manufacturing of NK CAR with a really good response rate in those patients. So the short answer is a good target, is a good cell, because what cell you use for CAR, that number is actually expanding. Some people using monocyte, macrophages, and the numbers goes up. But after T, probably the best next one is gonna be NK cells.
Thank you. Another question by Dr. Roham Dehimfar. I think he wants to ask his question directly.
Sure.
Please open his line. Dr. Dehimfar, do you hear me?
Can you hear me?
Yes.
Yes, please.
Dr. Ghobadi, thank you for your excellent presentation. I ask a question about treating T-cell malignancies using CAR T cells. You said that one of the problems in this field is isolation of CD8 plus T cells, healthy CD8 plus T cells as a source for generation of CAR T cells. As a solution for this problem, can we use iPSC or induced pluripotent stem cells? Differentiation of induced pluripotent stem cells to CD8 plus T cells, and then we have malignancy-free, healthy CD8 plus T cells for generation of CAR T cells. Can we do this?
Yes, absolutely. Absolutely. It's a good question. So, as a full disclosure, I put it on my second slide. So I'm a principal investigator of a trial that is open just only in 4 centers in the world with Fate Therapeutic that uses iPSC-derived INK CAR T. And I'm treating patients with those cells right now, and I've treated patients. That platform, I think, is a very attractive platform. Obviously, because of confidentiality, I can't go over the things. It's just has been basically press releases that is out there about that product. Yes, that iPSC derived probably is. I'm not saying that that's going to be the only future thing, but you can imagine if you want to give this this CAR T or CAR modified cells to patients and all around the world, and the countries that they can't basically afford $500,000 for a bag. If you have a cell bank that you can manufacture and just give you the cells that you want all the time, that's going to be the least expensive, most efficient way of producing these cells for patients around the world. It's a very attractive platform. We just have to see how it goes.
Okay, thank you very much, Dr. Ghobadi. That was great, very nice. And I hope see you in Tehran. Take care and have a nice time.
Thank you very much.
Goodbye.
Thank you very much. Thanks for having me here. Bye-bye.
Bye-bye.